Good morning and welcome to the Tarjan Center Lecture Series. Before Dr. Elizabeth Lawgeson officially introduces today's speaker, please allow me to address a few logistical items. To ensure the quality of the presentation, please do not share or use video or other applications. As we proceed through today's lecture, our presenter would love to respond to questions that arise from or that are related to the content of the presentation. Please look at the bottom of the Zoom program display where you will find a chat or text box. We are asking that you insert your questions into the chat box throughout the duration of the lecture. We will address your questions and welcome you to submit as many questions as naturally arise. You may ask questions through the chat feature at any time. This may be a good time to test the chat function. Please take this opportunity to enter a greeting into the chat box. Thank you. Before the end of the presentation, we will be inserting a link into the chat feature. It essentially is a link to the evaluation of today's lecture. Please complete the evaluation as your feedback will provide useful information to assist us in planning future lectures. Thank you in advance for that. And now, without further ado, here's Dr. Elizabeth Lawgeson.
Well, good morning, everyone. I'm Liz Lawgeson. I'm the training director for the UCLA Tarjan Center, which, as you may know, is our University Center for Excellence in Developmental Disabilities. I'd like to begin by welcoming you all to our monthly lecture series on behalf of the Tarjan Center and our co-sponsors, UCLA CART, which is the Center for Autism Research and Treatment, and the UCLA IDDRC, which is the Intellectual and Developmental Disabilities Research Center. So we appreciate your attendance at this lecture, particularly given these uncertain times. We hope that you and your loved ones are staying safe, and we hope it won't be long before we're all able to meet in person again. Additionally, I also want to thank our tireless Tarjan Center staff for putting this lecture together. In particular, a big thank you to Christina Martinez, to Beth Stoffmacher, and to Will Francis for organizing this event. So with that said, it's my pleasure to welcome our distinguished speaker, Dr. Lauren Clark. By way of background, Dr. Clark began her clinical nursing career as a public health nurse. She received her Bachelor of Science in Nursing, her Master of Science in Community Health Nursing, and her PhD in Clinical Nursing Research, all from the University of Arizona. Her research focuses on healthy lifestyle and maternal child health in the disability community, as well as advancing quality of life for people with intellectual and developmental disabilities and their families, which has included developing a survey of health-related quality of life. After joining the UCLA School of Nursing last fall as the Shapiro Family Endowed Chair in Developmental Disability Studies, Dr. Clark has helped to revamp the admissions process to be more inclusive of students with disabilities. This quarter, Dr. Clark is also teaching health policy to new nurses, and she makes it a point to highlight disability policy in particular. On a personal note, the Tarjan Center is very excited to be partnering with Dr. Clark to forge new alliances with individuals with disabilities and with agencies and policymakers to increase access to high quality healthcare. It's just really been a wonderful experience working with such a dedicated healthcare professional. So today, Dr. Clark is going to be presenting what I'm sure will be a very informative lecture on how nurses can support self-determination for people with developmental disabilities. So a big welcome to Dr. Lauren Clark.
Thank you so much, Dr. Lawgeson. And thank you so much to my colleagues at the Tarjan Center and to all the professionals and community members who are joining us today. I'm happy to be here. Let me tell you just in an overview what we're going to be covering in the next 45 minutes or so. The first half of the presentation, I'd like to focus on our first objective. We will identify current events and talk about those and how they challenge nurses' decision-making about care for people with developmental disability. And the topic on all of our mind could be coronavirus. There's also been some change in transplant policy and behavior modification. And for the second half of my lecture, I'll talk about how nurses implement health policies that affect people with developmental disability. And I'll cover informed consent, supported decision-making, and mandatory reporting of child abuse. And even though I'm talking about nurses here, because I'm a nurse and I feel most comfortable advancing nurses' knowledge in this area, I also really think that some of these concepts and ideas are interdisciplinary. So if you have thoughts or comments about that, of course, you can put those in the chat box and we'll get to those questions at the end. Because I'm talking about self-determination, I want to start out with a little discussion of what is self-determination. And according to the Developmental Disabilities Act, self-determination activities result in individuals with developmental disabilities with appropriate assistance having the ability and opportunity to communicate and make personal decisions, talk about their choices and exercise control over the type and intensity of services and supports they receive, the authority to control resources and obtain needed services, supports, and assistance, and opportunities to participate in their communities, including opportunities to influence policy and policy making. So that's a lot of the language from the DD Act, but I think we can summarize here and say people who are self-determined make things happen in their own life instead of having things happen to them. The American Association of Intellectual and Developmental Disability joined with the ARC, and they wrote a joint position, and it said much the same as the DD Act. It's the same right all people have, that right to self-determination. It's freedom to control one's life. And they also made the point that self-determination is independent of guardianship status. And they made another important point here. Other people can collaborate to achieve an individual's goals and facilitate their self-determination. So like all of us, we get by with a little help from our friends. All of that is a very optimistic way of thinking about, and realistic, I should say, thinking about self-determination for all people. But the reason it's particularly poignant for me is that it comes against this backdrop, a historical backdrop, that was recently revived again by the New York Times. And in February of this year, the New York Times did a retrospective and brought back to our attention the beatings, burns, and betrayal Willowbrook's scandalous legacy. And many of you will know or remember that Willowbrook is now an infamous state school that was populated by children with intellectual disabilities, and it was in the Willowbrook neighborhood on Staten Island in New York. It opened in 1947, and it was at that time designed to house about 4,000 children with intellectual disabilities. As it turned out, it became more and more crowded. Staff there who worked to feed these little children had about 3 minutes per child to feed them. And given both the impairments of the children and the speed with which the staff were working, many children became emaciated. There's also a suggestion that there was experimentation done at the school. And in general, the conditions were just deplorable. By the time Robert Kennedy visited the school in 1967, there were 6,000 children living in the space that was designed for 4,000. And he called it a snake pit and began some of the public attention that led to federal disability rights legislation and protections for people with developmental disabilities. I find it so sobering to consider that with all of the public outcry, it took until 1987 for the Willowbrook School to close. So historically, this idea of self-determination is really coming at us as rooted in some ways in our history, and it's not a great history there. Self-determination is also
to determine what the best thing is overall. Try asking me something more specific.
Oh dear. Self-determination is also related to quality of life. And I'm going to look at 3 current events with you, and we'll talk about self-determination and quality of life. To get started, I'd like to do an engagement activity with you, and this will make it kind of fun. So let me explain how to use PollEverywhere. If you're using a telephone, like a cell phone, the easiest thing to do is open up your cell phone calling app and enter in the phone number area this number, 37607, as if you're going to dial 37607. Then in the message box where you typically type a message, text Lauren Clark 430. It doesn't matter about the capitalization, that doesn't matter. And by no means should you have any spaces. It's all one long word, Lauren Clark 430. And if you could push the send button, send Lauren Clark 430 to 37607, you will get back a response that says that you've now joined my poll. And that's what you want to see. And then just hold that open because I'm going to be asking you to participate in the poll in a second. If you're using a computer, the URL is right there. Please go and get started with the computer. So let's give this a try. I have a couple of polls set up in the presentation. And I would like you to consider for a moment, are you happy with your life? And I don't mean this in a joking way. I'm quite serious. It would be nice if you seriously consider that question. Are you happy with your life? And if you say yes, then enter letter A and press send. If you think you're happy with your life most of the time, enter letter B. If you think you're happy with your life once in a while, letter C. And if you're not really happy with your life, enter letter D. And I'll give everybody a moment or two to participate. The way this works is it updates us with real life responses as more people weigh in through the poll. I'll also tell you it's completely anonymous. I don't know what you're answering, and nobody else will know either. Okay, it looks like most people are pretty happy with their life most of the time, and some people are very happy with their life pretty much all of the time. Good, let's keep that in mind. 60% say most of the time. Now, I want you to think about people with Down syndrome and think about that question that could be posed to people with Down syndrome. How happy are you with your life? And I want you to imagine what % of people with Down syndrome would answer as you did. Yes, I'm happy with my life, or yes, I'm happy most of the time. So keep your poll open and respond to this question as if you're answering the question, how happy are people with Down syndrome with their life? Yes, meaning most of the time or all of the time. So are 95% of people happy with their life? 85, 65, 45. Choose the letter that corresponds. Good, good. So it looks like maybe 65% of people with Down syndrome would say they're happy with their life. That's about the same as what we said in our group. And indeed, these are the very questions that Brian Scott Coe and his research team in Boston asked of 284 people with Down syndrome who were 12 years old and older. They wanted to know what is the quality of life of people with Down syndrome, and they asked them 3 questions. Are you happy with your life? Do you like who you are? And do you like how you look? And the answers they got were these. 99% of people with Down syndrome said they were happy with their life. 97% liked who they are, and 96% liked how they look. And this just goes to show me, and I think shows all of us, the quality of life as it's experienced may not be the same as quality of life as we project onto another group. It also reminds us of the disability paradox, that when someone who does not have a disability thinks of people with disability may be an inaccurate and lower estimate of quality of life than people themselves report. This really matters because quality of life is a factor when we come to estimating QALYs. So let me back up and say quality of life as we understand it is life satisfaction and well-being. And that's important when people are estimating healthcare, treatments, or resource allocation. And to make it easier to figure out what kinds of quality adjusted life years we're saving by implementing a treatment or intervention, The QALY is a metric that can be calculated, and that metric evaluates how a treatment might optimize resource allocation through rational and explicit methodologies. So the QALY is really a formula. The time or length of life extended, and the utility or the increase in quality of life. So in the figure, you can see that without treatment, the blue line, if someone has, for example, untreated hypertension, over the course of their life, the quality of their life may be decreased and they may die a slightly early death. With treatment for hypertension, the red line would show that not only is their length of life extended, but the quality of life in those intervening years is higher as well. So the QALY is the gained quality and length of life from treatment. This is important because when it comes to allocating resources, formulas like this are considered. When it comes to people with disability, and let's say COVID, people with disability are at a greater risk of contracting coronavirus because of physical barriers to access hygiene facilities, the need to touch things, difficulty in enacting social distancing, in fact, our reliance on other people at times to get things done, and difficulty accessing information. So we know that there's greater risk of infection, but there's perhaps a question about equal opportunity for treatment. And in the process, is there loss of day-to-day support during this time of COVID? This is a really compelling photo essay that was put together in Connecticut. And here we have two different families who have just been experiencing the coronavirus pandemic, as we all have. And the family on the top left said, the mother said that her son has become less and less verbal and no longer talks to her, but texts her. They used to work together in this store, but because the store is closed, they're no longer going to work and the schedule is disrupted and the life-fulfilling experiences he's had have been cut back. Similarly, the family on the right, she and her parents reported that a schedule is very important. She looks forward every day to riding horses, to going to a day program, and that it's been so hard to adjust to some of the social isolation that has come with COVID. But that's not to say that quality of life is affected the same for everyone. And in fact, when it came to quality adjusted life years and trying to take into account how those might factor into rationing or allocating resources, the National Council on Disability issued about a year ago this report, Quality Adjusted Life Years and the Devaluation of Life with Disability. And part of the argument they advance is that there are real ethical concerns about using QALYs as a factor in resource allocation. What you see here is a statement from the ARC, and they filed on behalf of people with disabilities a complaint about the illegal discrimination that is putting the lives of people with disabilities at imminent risk. And through this lawsuit, filed in the states of Washington, Alabama, Tennessee, Utah, and Oklahoma, they submitted that this is a violation of the civil rights of people with disabilities, and it's also in violation of the ADA and Section 504 of the Rehabilitation Act and a section of the Affordable Care Act as well. And in response, there has been guidance that's been issued by these states and by HHS as a whole that protects more explicitly the rights of people with disabilities to access treatment related to COVID infection. How this affects people is something that I think Ariel Henley can explain far better than I. So let me show a brief video clip.
My name is Ariel Henley. I live in the San Francisco Bay Area. I grew up with Cruzon syndrome and facial difference or disfigurement. As a result of that, I am a writer and activist and work in disability support services at the University of the Pacific. I've seen a lot that concerns me, both the message that we should just take one for the team, basically. Which that's kind of horrifying, and just sort of, from a personal standpoint, just kind of knowing that if I were to catch this virus and have to go to the hospital, I'm pretty much going to be out of luck and on my own. That's really terrifying. And knowing that it expands to a whole lot of people, and it's just sort of accepted by a lot of people is very upsetting to me. It's just what we have to do, and it's just the policies of the hospital. We have to ration things certain ways, disabled, non-disabled. We are all people. We're all people with lives and loved ones. Our lives have an inherent value. I mean, as somebody who grew up looking different, I can tell you my worth and everything about the person I am is tied to my appearance. And every single time I go to the hospital, I feel like I have to justify my humanity and prove that I am a valuable member of not just our local area, but hey, please treat me with respect, help me, because I want to stay alive even. And that's really what it comes down to, is can you please respect my personhood? It is fine. We did it.
So just to summarize so quickly, I think Ariel made such a compelling argument that access to treatment for COVID is tied to her personhood. And that's certainly something that nurses can understand. There's another quick in the news moment here. The FDA banned recently electrical stimulation devices for injurious or aggressive behavior. And what that means, I think, is illustrated quite well in the next brief video.
How many times a day do you think you were shocked?
In the beginning, I was shocked every day.
Jennifer Masumba has autism. For 7 years, she lived here at the Judge Rotenberg Center in Massachusetts, where she wore a backpack like this one, sometimes 24 hours a day. Inside is a device attached to electrodes that deliver a shock whenever a staffer presses a button on a remote carried on their belt. The center claims it stops bad or aggressive behavior.
I felt like I was being punished for being born.
How many?
So here we have a second example of a current event where quality of life and access to humane treatment has been considered, and the FDA made a ruling that no longer would people be allowed to be shocked as a form of behavior therapy. I think the third current event that comes to me as an example of quality of life and self-determination policy that nurses can care about is this statement that just came out 2 weeks ago by the American Academy of Pediatrics. And it says in brief that children with intellectual and developmental disabilities should be eligible, as are all children, for consideration for solid organ transplant. And it says here in the policy statement that denying a transplant to otherwise eligible children with disabilities may constitute illegal and unjustified discrimination. Children with intellectual and developmental disabilities should not be excluded from the potential pool of recipients and should be referred for evaluation. So when I take together those three current events, the coronavirus, the behavior modification, and transplants, I can really see that it's a work in progress. We have here just a brief timeline of some of the changes that have happened in developmental disability and disability policy over the course of the last 100 or so years. And there have really been, since I suppose 1968, a number of notable legislative actions that have put in place respect for personhood, autonomy, and access to the freedoms that self-determination brings. So the really kind of, what I say, the great news for me is that there's still progress being made, that it didn't end with the passage of the ADA in 1990 or any of the succeeding legislative actions, that it's really still in progress. So we've covered some of the current events that bring to mind quality of life and self-determination. I'd like to talk now about some more specific policies in the healthcare arena, and the first being informed consent. And just as a basic review, informed would mean that people know and understand the procedure that they're consenting to, and they're fully informed of risks and benefits. And consent would mean that based on that full information, they're voluntarily electing to take part in a surgery or a treatment or what have you. So voluntary and informed consent is indeed important. So this is a kind of another current event. And this is a headline taken from National Public Radio in early April that said that an older adult with dementia who lives in a nursing home is solicited to participate in a study of off-label use of hydroxychloroquine to treat a confirmed case of COVID. So the salient information here is this is a woman who has dementia and is being asked to take off-label hydroxychloroquine. So I'd like you to think about that. Who would be able to give consent on her behalf? Or is she going to be able to consent for herself? And with that in mind, if you could go back to PollEverywhere, if you think that the Adult Protective Services should give consent for her to take part in this trial, put A. A legally authorized representative, enter B. If her family member should give consent on her behalf to take part in the drug trial, C. A physician or nurse would be D. And if the patient herself could consent, why don't you put E? Any of those answers. Let's wait for a minute and see who should be consenting for her treatment. Good. It looks like most people think a legally authorized representative. Well, I'll tell you right now, the spoiler is that the medical director of the nursing home decided to initiate treatment and did not secure consent. He just decided to begin treatment with this experimental regimen. Let's look at how that would stack up against UCLA health system policy and against the opinions you expressed as well. This was not a UCLA patient, but if this had been a question that happened here at UCLA Health, there is a policy, and this policy talks about who may give consent. And so a nurse, any of us, would look at this. There's a section 2 that speaks specifically about adults who lack capacity to provide consent. In this case, the woman with dementia may be that person. Other persons who may give consent in non-emergent medical decision-making for an adult who lacks capacity would be, in this order, number 1, a legal representative. And that is a surrogate identified by the patient, maybe through an advance directive or a conservatorship. And that person is legally the representative who should have been approached with an informed consent decision. And those papers would be filed in the medical record. If that's not a possibility, then a family member, if there is no official surrogate, could be approached. All right, so we are thinking more about informed consent. Let's try our skills here with this one. As a nurse, who gives consent? In this case, an 18-year-old with a moderate intellectual disability is brought by parents for surgical sterilization. And there are several elements here. Again, we have an adult with potentially impaired capacity, and we have parents who are available. Who would be the most appropriate person to offer informed consent? If you go back to PollEverywhere, should it be Adult or Child Protective Services, the patient, a legally authorized representative, the parents who are standing there, family members, a physician, or a nurse? Okay, perhaps the patient, or maybe a legally authorized representative. If we go back to UCLA Health Systems policy for this hypothetical example, under section 2 that we just looked at about adults who may lack capacity, it does say under no circumstances may an agent, conservator, or relative consent on behalf of the patient to sterilization. So the germane question then is, does this adult have capacity to consent? And if not, is there a court order or similar legal documentation that would support the procedure? If not, I think it is the nurse's role as an advocate, in fact, all of our, within all of our roles, to make sure that there's a pause while we assess, is there appropriate consent for such an important procedure? Here's another hypothetical example. Who would give consent? A 2-year-old is checked in for an outpatient tonsillectomy by her parents. You as a nurse notice that both parents have an intellectual disability. Who would consent on behalf of the child? Would it be Child Protective Services, a legally authorized representative, a family member, the physician, or the patient herself? She's only 2, so I would say it may not be the patient herself, PollEverywhere. But I will say that this is probably a great example of where the nurse can, again, take a pause and make sure that informed voluntary consent has been provided to the parents. And if there's any doubt about any of the informed consent process, nurses have the ability to advocate for the patient and for the family, slow the process, and make sure that adequate informed consent is provided. This segues nicely into a discussion of supported decision-making. And supported decision-making is that principle that none of us are an island unto ourselves, and as we're faced with important healthcare decisions, we often reach out to those around us to help us think through the options, risks, and benefits and come to a reasoned decision that matches our values and desires in life. I want to contrast this with shared decision-making. And in the nursing literature, we talk a lot about the nurse and the patient sharing decision-making and figuring out together what is the best course of action forward. They dialogue together, they think about the patient's lifestyle, and they try and come up with a treatment plan that will be effective and resonate with their values. That's shared decision-making. Supported decision-making, in some ways, is an even bigger group of people. There's the family, sometimes trusted others, sometimes dear lifelong friends, sometimes people we love, and of course, people that we interact with in the community, our friends and family. That's the idea behind supported decision-making, that sometimes it's more than just the provider and the patient, but the other people in our lives that can be part of helping us make important decisions. This is a brief video clip about Gabby, who has an important healthcare decision to make and how she experienced supported decision-making.
I was born with spinal bifida. I've had to deal with a lot of surgeries that has to do with it. Having to decide myself, it was really hard. But now that I have a lot of people that help me make decisions, it's a lot easier on me. For the longest time, and still today, people with disabilities are thought to not have the ability to direct their own lives.
There's an assumption that a person with a disability is a perpetual child, and guardianship or conservatorship makes that assumption a legal reality.
We essentially take away the legal status of an individual. We say this person is incapable of making decisions themselves, and so we are going to appoint someone else to make the decision for them. Most people with disabilities are able to make their own decisions, and there's no reason why we should be taking that autonomy away. Now there's a newer concept of supported decision making that says people can make their own informed choices. They may need support to do so, but let's offer that support so that everyone can have independence. Supported decision making to me is really exciting because I think we're talking about people taking their own personal problems.
So after listening to Gabby explain supported decision-making, I think we're in a good position to say, how does it work? How's it related to informed consent, and who ultimately benefits from supported decision-making? How does it work? Well, it starts at home for most people, and the person with the disability will choose their own trusted advisors and supporters. And the supporters agree that their role in the process is simply to help clarify values, help the person understand information, and communicate their decision. They're not there to make the decision, but to support decision-making. And supported decision-making uses tools and decision aids. And my favorite among these is this idea of plain language materials. And I highlight this because I think plain language materials really got a boost in the disability community, where advocates suggested that it was our job as nurses to provide information that was accessible through plain language. And it is exactly, it says what it means. And not only has that improvement in healthcare been an advantage to people with a variety of disabilities, it's been an advantage to lots of people, people with other kinds of literacy issues, with English language learner issues. And so we can thank the disability community for pushing the envelope there. But the other kinds of decision aids and tools that I've seen and have used, in fact, and found very effective is allowing extra time to discuss choices, creating a pro-con list. My favorite is role play, and often with my own son, we have done lots of role playing. Sometimes I play his part, and I really ham it up. Sometimes I play the part of the nurse or the physician, and I have lots of personas there, the bad nurse, the good nurse. It doesn't matter, it's tons of fun. And by going through role play, we're able to practice communication skills, and he's able to practice expressing his desires and hopes and his decisions directly to the provider. Supporters who take part in supported decision-making often attend meetings or appointments, and they can aid in question recall, they can aid in clarifying information. And sometimes, if you're in a supported decision-making team, you'll be asked to fill out a form, much like a HIPAA waiver that will go in the file. If you want more information, there are a variety of places where you can learn more about supported decision-making. So I'm going to ask you to do a little thought question here, and you're going to submit a vote back to PollEverywhere. And I want you to answer the question, compared to our standard consent process, what benefits might be possible from supported decision-making? In other words, if you're going to text a word or two, what's the advantage of using supported decision-making rather than not? And you can think about the advantage to the person with a disability, the advantage to the supported decision-making team. Is there an advantage to the nurse and the care team? And is there a healthcare system advantage or even a social advantage? So this is going to produce a word cloud, and everything that you type is going to show up here in our word cloud. So if you can go back to PollEverywhere and think for a moment, what would be the benefit of supported decision-making? Go ahead and type that in. Personal choice or agency. I'm sorry this is small. It's supposed to be a big, colorful graphic, and it's not working that way. A personal choice. It's safer. It preserves dignity. Great answers. Safety again. Good. Care providers have more confidence in the decision made. Absolutely. It preserves the rights of the person. It's person-centered planning. Yes, person-centered. It supports their autonomy and their decision-making capacity. Self-determination, brilliant. Excellent, good answers, good answers. So just to summarize what you already know, supported decision-making isn't inserting a substitute person or a durable power of attorney. It's a way to slow down the process so that we can ensure a more informed, more voluntary consent. And then in terms of our last consideration, for nurses who are working with people with disabilities to secure quality of life and self-determination, mandated reporting of abuse is something that we really should consider. And it's helpful to think back about how nurses became mandated reporters. Back in 1962, Henry Kemp at the University of Colorado published a very influential paper where he reported that parents were physically abusing children, and there were a variety of instances, case examples that he presented, and it was termed battered child syndrome. And this was so alarming and of such concern, not only in the medical community, but in society at large, that California and Idaho were the very first states to enact mandatory reporting. And that means by virtue of being a trusted healthcare professional, you are required by law to report instances of child abuse. By 1967, 49 states had adopted mandated reporter of suspected child abuse laws. And when it first got started, it was limited to physical abuse, and the only known mandated reporters were physicians. And that, as you all know, has changed over time. By 1974, the US Congress enacted the Child Abuse Prevention and Treatment Act to standardize reporting. So rather than having a patchwork of state laws, there is now this undergirding of federal law around child abuse reporting. As a result of that policy, the National Child Abuse and Neglect Data System, or NCANS, was established. And that is a database that can be used for research and descriptive purposes, so we better understand trends in the nation around child abuse. There's also been an expansion over time in who is a mandated reporter. And now more professionals, and in some states, everybody, universal mandated reporters, more professionals are required to report child abuse or suspected abuse or neglect. And that expansion of mandated reporting has transformed from simply physicians to include nurses, teachers, social workers, many other professionals who in their capacity may be aware of child abuse or neglect or adult abuse and are required now to report that. Universal reporting is a more recent phenomenon, and that has come about because I think people have asked a very logical question. If it's good to report, and if somebody other than a nurse or a physician or a teacher sees child abuse, should they not as well be obligated to report that? And universal reporting is now the law in some states, and that has resulted in an increase in reports by about 25%. There is a little bit of question around universal reporting, however. Additional reports will be made, say these authors, but not necessarily resulting in more maltreated children found, especially the seriously abused children who have not been found in higher numbers as a result of universal reporting. In talking to people and in doing some reading on this, one of the concerns is that with universal reporting, the investigators who are sent to investigate these reports are overworked, and in some cases, they have a more difficult time following up on some child abuse reports because of the sheer volume of reports that may or may not be meet the criteria. So let's look at nurses. What is their mandated reporting responsibility? And here is the abuse reporting requirements as listed by the State Board of Registered Nursing in California. And it says here, nurses are among those practitioners who must report known or observed instances of abuse to the appropriate authorities. And nurses are taught about this in nursing school. If you go to the California Penal Code, it tells us all a little more about what that means in detail. And it says, first of all, the nurse should report as soon as possible and no later than 36 hours after observing the abuse. The report should be filed with the California Department of Social Services. And if you click on the link to that, you will see this screen pop up. And this is how you report abuse. And if the nurse fails to report abuse, the nurse will be fined $1,000 and a misdemeanor charge will be filed. And that has happened. So let's consider, knowing what we know now about nurses as mandated reporters, how a nurse in this situation could respond. In 2013, Miss Gordon, who was age 19, and has a developmental disability, gave birth in Massachusetts, and a nurse called Child Protective Services at day 2 postpartum. There are a few details here that you should know. The first detail is that Miss Gordon was attended by her mother, and her mother had quit her job and decided that she would be full-time available to assist Miss Gordon with bearing and raising this child. Unfortunately, the nurse who was caring for Miss Gordon did not know that and didn't know what kind of support Miss Gordon had at home. But the nurse did notice that Miss Gordon, day 2 postpartum, was still having some trouble holding the baby and some trouble feeding the baby. And based on those observations, she filed a child abuse report. What happened thereafter is the investigation proceeded, and the child was removed from mother's custody and thereafter placed in adoption proceedings. Ms. Gordon and her mother retained an attorney, and in 2015, 2 years after this had happened, the Department of Justice ruled on this case, and they said there had been no offer of services and no accommodations made for Ms. Gordon throughout the proceedings. And they said that it was essential that the state work toward a reunification of the mother and the baby, and do so with appropriate accommodations to assist Ms. Gordon and the baby to live as a family again. And this is really, I think, a tragedy for the family who missed out on 2 years of bonding with that baby. They certainly missed out on breastfeeding. A tragedy, I think, for all of us as we think about the nurse who may have been trying to do her best to protect and assist a family, but who started in motion a series of events that nearly led to the termination of parental rights. And that makes me think about alternative endings. There are other ways that parenthood can unfold for people with developmental disabilities. This is a picture of Marie, and she's pictured here with her son. And she wrote a blog. It was called Disability in Parenting, How Possible Is It? And it's at this website. And Marie wrote about what it's like to be a mother with a disability and how it is possible with support. Then there's some text over on the right, and this comes from a different mother. Her name is Ivanova, and she wrote, medical professionals have this assumption that we as parents with intellectual and developmental disabilities can't take care of our kids. And I think about assumptions and the assumptions we made at the beginning of this talk about quality of life. And I think all of us have lots of assumptions we make, not just about quality of life for other people, but also about capacity or ability to care for children. Even Nova goes on, Child Protective Services sometimes does take babies away from families. And that's something I want to change. I want to make sure that parents can get the supports they need. And that reminds me so much of the language about self-determination in the DD Act. That here's Ivanova, a mother with a developmental disability, saying she's going to take an active role in establishing policy and supports for families. So all said and done, we've talked a little bit about coronavirus, transplants, and behavior modification, but we've spent a little bit more time talking about informed consent, supported decision-making, and the thoughtful and careful reporting of child abuse. And just to summarize, I'd like to say that everyone that we've talked about today, people with disabilities and their supporters, are unique individuals. There's a lot of heterogeneity, and we all have very, very similar rights, the right to self-determination and the opportunity to self-direct and enact quality of life consistent with our values. The quality of life is also experienced by each one of us within a context of family and community. And our quality of life is shaped by other life circumstances and by history. And when we think about developmental disability and self-determination, we can really think about it as part of the spectrum of normal for human beings. And not only is it a lived experience, but it's also a political movement. And it's an identity. And so in this vein, our work as nurses can support individual and collective self-determination of all people in community and clinical settings. So at this point, I'd like to open it up to conversation and questions.
Great, thank you so much for your presentation. It took me a second there to unmute myself. Here's our very first question. The question is, have you seen a rise in the number of patients with supported decision-making teams over the more restrictive conservatorships?
Oh, that is a really excellent question. And I'm not sure that I'm in a position to know the answer to that. I would really like to find that out. And in fact, maybe I should ask, is there anybody here today in the audience that knows the answer? Are we gaining some traction with supported decision-making teams? And is that losing ground to the more restrictive conservatorship? I will say that the NDC has published a really nice guide about supported decision-making. And there was a statement in there that just caught my attention right away. And it said that there's a pipeline from school, especially special education programs, to guardianship. And in that pipeline, 58% of people with intellectual and developmental disabilities leave their school experience by age 22 with a guardianship in place. 58% in guardianship by age 22. And I just thought that was such a high number. And the NDC publication did say that there are ways we can think about that, and we can think about other options that preserve self-determination. And I was heartened to read that.
Okay, here's another question. What are some important public policies related to individuals with developmental disabilities currently under consideration that we should be aware of? And how might we get involved in supporting public policy?
That's a hard question. That's a hard question. I've been keeping up on these current events and this policy for today's presentation, and I kind of shared some of the recent successes. I don't know, of course, my mind is blank at this second. I am trying to think what is in the pipeline that has not been resolved. I'm sure there are a number of things in the pipeline. Let me write that down. I should think about this. I should have the answer to that, but I actually don't have an answer at this particular moment. Does anybody else know of something that we could, if you'd like, you can share it in the chat box. Other public policies or healthcare policies that we should be thinking about.
Mm-hmm. And how we might get involved in supporting public policy as well.
Right, exactly. I've been keeping my eye on the coronavirus, and it was really, I was wondering where we would be with that when I gave this presentation. But it looks like many of those questions have been resolved with the reporting out from HHS.
Thank you. So I'm going to encourage our audience to insert additional questions into the chat box while I read this question. I think you may have responded to this one a little bit in what you said during your lecture or after it. Do you have guidelines for when a more restrictive conservatorship would be more appropriate than supported decision-making?
You know, I do not have guidelines. And in fact, I think I would be way outside my scope of practice if I purported to. I think this is such an important decision because it curtails self-determination. And I think because there are a variety of ways to get that done, various ways to limit decision-making in certain domains, financially, healthcare, etc., that it's pretty important to think about all the ways that can be done in a way that's judicious. And so I would suggest that people consult with others. Definitely, there's the legal option and discussing this with a lawyer. I think there are also parent centers that might be able to offer some support and some consideration of this question. And I think giving it all due time and consideration is the most important part, so that the right decision is made in each individual circumstance.
Thank you for the question. What could a nurse do for someone with IDD who came in without a support group and you felt they needed one?
Oh, I think that would be such a nice opportunity for the nurse to talk with the person and see if there is anyone else that they might like to have present, available by phone or physically present, to help them make some decisions. I know that clinical spaces now are quite restrictive in who might be physically present, but I think it's quite possible for the nurse to assess with the individual what kind of support would help them at this challenging time, and how might that person or group be brought into the conversation in a way that meets their needs for support, information, values clarification, and so forth. So I think the best place to start is with the patient and acknowledging that you would love to see them fully supported in making decisions in the healthcare arena, whatever that looks like to them.
Thank you for that. Next question, what types of resources or where can people go to find information about self-determination and ways to live more independently, particularly if other medical conditions cause a temporary increase in need of support?
Oh, and I see Catherine asked that question. Excellent question, Catherine. I popped up on the screen, and I can probably go back to it. I popped up on the screen several places where someone could go, and let me just mention those here out loud. One place that I found very helpful was the ACLU Disability Rights Program, and you can find that on the internet at aclu.org. Another place was the National Resource Center for Supported Decision Making, and that was terrific as well, supporteddecisionmaking.org. And then the Quality Trust for Individuals with Disabilities, and that was dcqualitytrust.org. So in preparation for today, I consulted all of those sites and others, and I think that's where I would go to look for some resources to find out more and begin the process of putting together a supported decision-making plan and team.
Thank you so much. Dr. Lageson?
Well, I'd just like to end by thanking Dr. Lauren Clark for her very informative lecture. It was very interesting, in particular hearing the history of disability policy. I found incredibly interesting and illuminating. Thank you for your interactive approach to giving this lecture today. That was really lovely and refreshing. And thank you all for attending today's lecture. We appreciate your attendance at the Tarjan series. We look forward to hopefully meeting again sometime soon in person, but in the meantime, we wish everyone safe and happy. And once again, thank you so much to Dr. Lauren Clark.
Thank you.